Hello, my name's Alex Wickham. I'm a consultant anaesthetist at Imperial College Healthcare. I work predominantly at St Mary's Hospital, but also at the Hammersmith Hospital. My regular weekly practice comprises anaesthesia for esophageal gastric cancer work, vascular anaesthesia comprising both open and endovascular aortic works and peripheral vascular work as well. I do some benign upper GI work and also have a role in major trauma and pre-assessment clinic where I optimise and manage patients presenting for vascular surgery. There is no universal definition of intraoperative hypotension. We've known about it as a problem for a long time, and when I first started becoming interested in the subject back in sort of 2013, 2014, there were recommendations that we avoided, or based on the literature, that we avoided mean arterial pressures of less than 55 millimeters of mercury. Over the intervening 8-9 years, that has changed and those values have been revised upwards, and there have been a number of different documents providing different recommendations. If you look in the literature, there was one study back in 2007 where they found 140 definitions in 130 research studies, so there was no consensus back then. Now, more recently, with the Association of Anaesthetists guidance in 2014 on perioperative care of the elderly, and more recently the perioperative quality improvement statement from, I think, 2019, 2020, and another one from 2021 from a French group, the recommended thresholds at which we would treat hypotension have been revised upwards. So now the recommendations are that we should avoid a systolic pressure drop of over 20%, and we should aim for mean arterial pressure thresholds above 70 millimeters of mercury, 60 to 70 millimeters of mercury. Blood pressure didn't used to be routinely measured until about 1900, when Harvey Cushing, a brain surgeon, suggested that it would be a sensible thing, particularly in patients sat up, I think, in the beach chair position. And then first signs of potential harm arising from it came about in a publication in 1923. So we've known about potential harms from hypotension for a long time. There was another study in the Lancet in the 1950s looking at not specifically intraoperative hypotension, but problems in the older patient after general anaesthesia and showing long-term cognitive dysfunction after anaesthesia. Didn't link it specific to hypotension, but anaesthesia in general. The modern interest in intraoperative hypotension was sparked by Dan Sessler's work on the triple low in the early sort of around 2010, and we've been looking at it more closely ever since as a marker of potential harm. I think since the triple low was first published, which is a triple low of low delivered anaesthetic concentration, low bispectral index, and low blood pressure intraoperatively. That was the first study that really piqued attention, which combined with a lack of a definition got researchers interested. Over the intervening 10 to 15 years, I think there's been increasing interest in the topic. There's been more research looking at, one, trying to quantify harms that are associated with it. Studies that I've been involved in trying to show how frequent it is and the mismatch perhaps between work as intended versus work that is actually done. And now more recently onto interventional studies looking at how we can potentially modify outcomes and treat intraoperative hypotension and hopefully try to prevent adverse outcomes. Intraoperative hypotension affects a large number of people. The actual figure would depend on how you define it, which is why we've been working to define it for such a long period of time. If you take a relatively restrictive threshold, say a systolic blood pressure of 100 millimeters of mercury, and then look at who becomes hypotensive based on that, 90% of patients will become hypotensive. If you put it to 50 millimeters of mercury and take a historical definition, then far fewer patients will become hypotensive. You can also look at the duration that somebody spends hypotensive and at different thresholds, and that will affect your definition or frequency. Overall, though, in the studies that I've been involved in, which were looking at the elderly, but across a variety of different surgical specialties, magnitudes of operations, urgency of operations, ASA classes, various different comorbidities, hypotension was extremely prevalent when you took a relatively middle-of-the-road threshold of 65 millimeters of mercury. 60 to 70% of patients across the board were becoming hypotensive. So it's extremely common. So hypertension to me is a readily modifiable risk factor that is associated with harm. It's really common. It's something that we treat routinely, and I think we could treat it slightly better. So iHype was a cohort observational study that took place across England, Scotland and Wales in 2014. We intended to define intraoperative hypotension by when anaesthetists said they would treat it and when they actually did treat it. So clinician-derived rather than research-derived definition of intraoperative hypotension. Because if you want to change practice, you need to see what current practice is. And we showed that intraoperative hypotension was common, that the duration was frequently prolonged, and that anaesthetists' perception of what they thought they were doing or what they said they would do, their intended treatment thresholds, differed from clinical practice across the board in different specialties, different urgencies of procedure, different magnitudes of procedure or surgical severity. We found it was very common and that people weren't quite doing exactly what they said they would normally do. So in the study, we looked at anaesthetic charts and matched up doses of vasopressor to a given blood pressure of a hypertensive event. We also then asked them afterwards when they would typically treat intraoperative hypotension. Most anaesthetists said they would treat a threshold of 90 millimeters of mercury or 80 millimeters of mercury as systolic, or a 20% reduction. The Association of Anaesthetists guidance was clearly has affected practice. What was interesting was that although they said they would treat it at, say, a 20% drop or 80 to 90 millimeters of mercury threshold, when you looked at the threshold values, there was good concordance. So people were treating at 90 or 80 or 100 millimeters of mercury. When you looked at percentage reduction, there was a far greater spread, and vasopressors were given at a much wider variety of mean and systolic percentage reductions in blood pressure. So there was less concordance with treatment as intended. So death is the ultimate endpoint in any study, and that's been associated with various different degrees of intraoperative hypotension in different cohorts from different research groups, as being associated with intraoperative hypotension at 5 days post-op, 30 days post-op, 1 year post-op. There's an increased risk of mortality if you are hypotensive by a given threshold. In some instances, the risk increased on a minute-by-minute, also cumulative duration. Kidney injury, using a variety of different definitions, has been studied as an outcome associated with intraoperative hypotension, and has been widely associated with various different thresholds and various different durations of hypotension. So it's one of the most widely studied outcomes, and it's one that we studied in iHype. We didn't show an association in the UK data set, so definitely associated. Myocardial injury, defined as a rise in troponin concentrations above the reference range for the hospital, has been associated with intraoperative hypotension in a number of studies and in one meta-analysis. Again, a variety of different magnitudes of hypotension and different durations, with some studies showing a relative risk that increases on a minute-by-minute basis. So intraoperative hypotension has been less strongly associated with stroke, and the link with delirium and postoperative cognitive decline hasn't been established. It feels plausible because if blood pressure is low enough for long enough, as we know from other settings, then nerve injury occurs. But the link hasn't been established, or the association hasn't been established. There was one interesting case control study back in 2016 which looked at somatosensory evoked potentials in association with and their presence or loss depending on intraoperative blood pressure in patients having spinal surgery. And as the blood pressure dropped, patients who were having their SSEPs monitored, they lost those signals. But as the blood pressure came back up, the somatosensory evoked potentials returned. And there was a greater frequency of neuropraxia, so post-operative nerve injuries reported in the patients who had the hypotension compared with those who didn't. It was a small study, but it was an interesting one all the same. So intraoperative hypotension has been widely associated with kidney injury using a variety of thresholds and durations. Myocardial injury has been widely associated with intraoperative hypotension using, again, a variety of thresholds and in a range of studies, including one meta-analysis. But the durations of intraoperative hypotension that were studied were slightly longer. So one study was looking at about 5 minutes of hypotension as an association. Others were showing sort of 15 to 30 minutes of hypotension was associated with cardiac injury. So intraoperative hypotension is common. So all patients are at risk of getting the low blood pressure during an operation. Who is at greater risk of getting adverse outcomes? It would be those who are physiologically or pharmacologically predisposed. So the elderly are particularly at risk. They have pre-existing heart and kidney disease. They may be taking medicines that cause greater degrees of hypotension for a given anesthetic technique. So the magnitude of blood pressure drop they have is greater. Patients whose tissues are already under stress, so people with diabetes, people with peripheral vascular disease are at greater risk. There seems to be a dose-dependent relationship between intraoperative hypotension and the associated adverse outcomes. So both the magnitude of hypotension of any given event and the time spent at either that isolated event or cumulatively over the course of the operation. The greater the time spent, the greater the depth of hypotensive event, the greater the risk of associated adverse outcomes. So intraoperative hypotension is managed in a variety of different ways. When we studied it in iHype, we looked at when vasopressor drugs were given because it was a thing that we could clearly associate on the anesthetic chart. But anaesthetists do a variety of things. Might adjust the depth of anesthesia, might give a fluid bolus, might give a pure alpha agonist or an alpha and beta agonist, to depending on what the patient's doing and what we think is the cause of the hypotension. So the Foutier study from 2017 was the first study which showed that tighter management of intraoperative blood pressure was associated with a reduction in the risk of adverse outcomes. This study randomized 300 patients across several hospitals in France to either control treatment, which was ephedrine boluses given if the blood pressure dropped to, I think, 40% below pre-specified starting blood pressure, versus the intervention arm, which maintained blood pressure within 10% of the starting value using a peripheral noradrenaline infusion. And it was the first study to show the benefit of tight intraoperative blood pressure control on reducing the risk of adverse outcomes. They used a composite score of systemic inflammatory response syndrome plus dysfunction in one organ system or more. It was a good, well-run study. Criticisms that have been levelled at it were that the control group were unrepresentative of normal practice. However, the iHype study showed that actually their control arm was representative of normal practice. The other criticism that's been levelled at it is that the composite outcome that they used, which showed the difference, was primarily made up of the systemic inflammatory response syndrome and delirium. Those are the two key things that changed. And delirium hasn't been associated with intraoperative hypotension in previous studies. But overall, it's a good study that, for me, underlined the need to change in practice. There have been other studies since. So the Fedora study from Spain looked at cardiac output measurements with intraoperative hypotension as one of the variables that was controlled in a randomized control trial. It was published in the BJA in 2018, and they showed a difference in composite adverse outcomes when the blood pressure was maintained above 65 millimeters of mercury, the cardiac index and stroke volume when they were optimized in addition. So another study has shown benefit. More recently, there was a study published in the Journal of the American College of Cardiology, which was a single-center randomized study looking at higher risk patients and randomized them to either control treatment or tight blood pressure control intraoperative, and looked at the composite outcome of kidney injury and myocardial injury. Now, they showed no difference between control and intervention group in that study. However, they used a composite outcome, and when you break those numbers down, as the accompanying editorial suggested, they weren't adequately powered to show that there was no difference. They needed several thousand patients more to show a difference. So in summary, we've had several studies looking at whether intervention makes a difference, mostly well conducted, and suggestive that a change, some suggesting that there is benefit to treating intraoperative hypotension, some suggesting there isn't, but a definitive study has not yet been conducted. There are several in progress though. So there are a couple of other studies. POISE 3, which was a large study from several countries, randomized controlled trial looking at two things: the use of tranexamic acid, which isn't relevant to this, and intraoperative hypotension. The tranexamic acid results have been published in the New England Journal of Medicine. The intraoperative hypotension results haven't yet been published, and they are due to be soon. There's a second study that's recruiting at the moment in the USA called the Guardian study. It's led by Dan Sessler, and that is looking at the management of intraoperative hypotension and whether aggressive management or versus control leads to a change in outcomes. In addition to simple methods, there's also cardiac output monitoring, and that can be delivered invasively with an arterial line, central line, or pulmonary artery flotation catheter, Swan-Ganz. It can also be delivered non-invasively using the Acumen IQ cuff, for example. And this technology allows continual measurement of blood pressure, cardiac output, stroke volume, and it also works as part of the hypertension prediction index. So I think the future for intraoperative hypertension management is really exciting. We've got studies showing associations. We'll have more studies showing where association perhaps moves to causation. There are studies looking at interventions to reduce those associated risks. And I think from there, we'll move beyond applying population-based figures and treating patients based on those towards more individualized care. We've seen an explosion of wearable tech. We've seen an explosion in intraoperative monitoring, for example, the Edwards Hypertension Prediction Index, which will allow us to move from population-based management to more individualized care. And I think that's where the future sits with hypertension management.